Hello, everyone. My name is Andreas Ralambus, and I am the president of the European Cancer Organization, board member of the European Oncology Nursing Society, and co-founder of the Cancer Nursing Fund. Warm welcome to everyone to this virtual meeting on informed and shared decision making. Before we start today's webinar, a few meeting protocols. To protect the quality of the audio for everybody, please stay on mute throughout this meeting. We encourage all participants to join the interactive discussion in the chat, so please feel free to ask questions, share thoughts and comments with the panelists. Please note that the meeting will be recorded. We recommend that you connect using side-by-side speaker view by activating it under the view in the upper right-hand corner of the Zoom window and selecting it from the options as you can see on the screen. On our meeting agenda today, we have the pleasure to have two sessions. The first one will be on shared decision making, chaired by Kathy Oliver, and session 2 will be on personalized patient information, chaired by Guy Byers. Then this will be followed by a summary and closure. As part of our 10 focus topic networks, we also have the Inequalities Network. This is chaired by Niccolò Matteo, Luca Battisti from the International Society of Geriatric Oncology, SIOC, which we will be hearing later, and also by Sarah Cohen from the European Association of Urology, EAU. So our Inequalities Network dedicates itself to driving consensus, presenting policy recommendations and solutions, and sharing best practices in relation to the inequalities challenges associated, but not limited, to the East-West divide, gender, ethnicity, age, sexuality and identity, health literacy and patient education, as well as other marginalized groups. As part of our inequalities networks, we have members coming from the member societies of the European Cancer Organization, such as EAU, ECL, EONS, E.C.O, just to mention a few, patients organizations such as ECPC, IBTA, but also invited stakeholders such as UICC and the World Health Organization. At this point, we would like to draw your attention to our recent publication, a paper on the Journal of Cancer Policy on cancer literacy in Europe, informing patients and implementing shared decision-making. The key topics from the article include health literacy as part of the patient-centered healthcare approach, cancer patients' needs and shared decision-making, impact on health outcomes, reliable information, misinformation in the digital era, helping the patient navigate, recommendations for improving cancer literacy in Europe. As I have mentioned, this paper has been recently published in the Journal of Cancer Policy. And at this point, I have the pleasure to give the floor to Kathy Oliver, co-chair of the Patient Advisory Committee of the European Cancer Organization, chair and founding co-director of the International Brain Tumor Alliance. Kathy, the stage is yours.
Thank you very much, Andreas. I hope everyone can hear me. Well, good afternoon, everyone, and thank you so much for joining us for this meeting on informed and shared decision-making. By way of background to our sessions this afternoon, I just want to remind you of the European Code of Cancer Practice, which actually is an important structure on which we have built this webinar today. The code highlights 10 important patient rights, and you see them all here on this slide. You will notice that right number 2 the right of a patient to information, and right number 5, the right of a patient to shared decision-making, are the cornerstones of our first session today. Next slide, please. Now, just let me explain a little bit about the code. It's a citizen and patient-centered statement of the core requirements for good clinical practice in order to improve outcomes for all of Europe's cancer patients. And that's what we want to achieve, much better outcomes for Europe's cancer patients. It was co-produced by a team of cancer professionals, cancer patients, and patient advocates. And as I said, it sets out 10 key overarching rights as to what cancer patients should expect from their healthcare systems. The code is an empowerment tool, and it's translated into over 20 different languages. And it's been endorsed by many European and national organizations, as well as individual cancer centers. Now, the code's 2 rights to information and shared decision-making are topics that are very, very close to the hearts of many patients who would like to be empowered participants in their own cancer care. In fact, as we say in our recently published paper on cancer literacy, in order to tailor treatment to their needs, cancer patients are encouraged to be more active and engaged in their care decisions and to be autonomous yet collaborative with their healthcare professionals when it comes to treatment in order to get better results. So with that thought in mind, patients developing a collaborative partnership with their healthcare providers, and to set the scene, we'd like to show you a short video from the region of Southern Denmark Center for Shared Decision-Making.
Shared decision-making. Who are you, really? What makes you different from everyone else? Some things are obvious to everyone around you, but others only become clear when you talk about them. Many achievements and experiences throughout your life have shaped you into the person you are. No 2 lives are the same. When dining in a restaurant, you choose from the options on the menu depending on what you would like, how hungry you are, and what you know you don't like. You do this because you are an expert at being you. This is also the same when, for example, you go to the hospital. The healthcare professional is an expert in treatments and diagnoses, but they know nothing about you. Not yet, anyway. Based on the knowledge you have about yourself and the expert knowledge of the healthcare professional, you can work together to identify the best choice for you. It's not a matter of you standing alone with responsibility for the decision. Using your knowledge of who you are, the healthcare professional can better support you in making the right decisions, regarding your treatment, for example. Remember, it's you who will have to live with the decision, so it's important that you carefully consider what it will mean for you. You may even want your close family and friends to help you. We call this shared decision-making. You're not being difficult because of who you are, or when you express your wishes or demands and ask questions about your treatment, for example. Sometimes you might find it difficult to decide what really matters to you and what's important. The healthcare professional can help you when considering these matters. The healthcare professional is there to help you, and you are there to help the healthcare professional to learn more about you. Together, you can help one another to take the very best care of you.
Okay, thanks very much. And I'd now like to introduce Stina Raff Sondergaard. Stina is a physician and PhD student from the Danish Center for Shared Decision-Making and the Department of Clinical Oncology, Villa Lillebælt University Hospital of Southern Denmark. Stina, I hope I pronounced your institution correctly. Please correct if I'm wrong, but over to you. Thanks.
Thank you so much, Kathy. Thank you for that nice introduction, and thank you everyone for the kind invitation to speak to you all today. I'm very honored. My name is Stine Rauf Søndergaard. I'm a medical doctor and PhD student at the Department of Oncology at Vejle Hospital in Denmark. My PhD is on shared decision-making with breast cancer patients. As you just saw, oh, please change the slide. Thank you. As you just saw in the video, shared decision-making is about making the right decision for that specific patient based on both evidence and patient preferences. It is a collaboration between the patient and the clinician, and in my opinion, focusing on shared decision-making makes my work as a doctor more rewarding. In the following, I will introduce you to how we are working with implementation of shared decision-making across 5 large hospital units in the region of southern Denmark. Next slide, please. But first, when we introduce shared decision-making to clinicians, we meet some barriers. The first time I heard about shared decision-making, I certainly thought, I'm already doing this. But fact is, once you try the concept in the consultations, you discover that you really weren't doing it, and definitely not every time with every patient. Another barrier is concern of bad decisions being made. However, in the literature, there is a trend towards more conservative decisions when shared decision-making is used. For instance, less screening for prostate cancer. However, there is no sign indicating that decisions are irresponsible in shared decision-making. On the contrary, shared decision-making may lower over-treatment. Another concern is learning something new and changing habits. And yes, the first couple of shared decision-making based consultations may be a bit of a challenge, but most of our colleagues find that soon shared decision-making is the new habit. Using an in-consult decision aid may also seem time-consuming, but from the literature and our practical experience, we know that it will not ruin your schedule. It may take a few minutes longer, yes, but not more than that. And what about the patients? Do they want this at all? Next slide, please. The Society's national surveys show that 3 out of 4 cancer patients prefer decisions about treatment to be made together with the clinician based on relevant information. However, 1 out of 3 Danish cancer patients feel that they are not sufficiently involved in decisions about treatment and care. Remember, shared decision-making is not about asking the patient, what is the matter with you? We're really good at that. No, shared decision-making is asking the patient what matters to you. That's what we need to do more of. Patient decision aids are tools that may be used before or during the consultation to facilitate shared decision-making. A sub-analysis of a Cochrane review has shown that using patient decision aids in oncology leads to improved match between the chosen option and the features that matters most to the patient, demonstrated by improved patient knowledge, more accurate risk perception, and value choice agreement. It also leads to an improved decision-making process, demonstrated by decreased patient decisional conflict, reduced clinician-controlled decision-making, and fewer patients being indecisive. Next slide, please. Oh, sorry, I think I skipped that for you. Thank you. So let's summarize. Our patients want us to practice shared decision-making. We have evidence that it has a number of positive effects, but data also show that our patients do not experience that we practice shared decision-making to a significant extent. Systematic approaches are urgently needed. Next slide, please. So let's move to Denmark. Denmark is divided into 5 regions that each organizes health services for their citizens. one of the regions, the region of Southern Denmark, where I'm located, decided to implement shared decision-making in the clinic at a regional level. Therefore, we are now in the midst of a regional implementation at all hospital units in the region of Southern Denmark. And here you see a map of the region of Southern Denmark with all the hospital units, 4 bigger ones and some smaller ones. The 5th large unit is the mental health care hospitals, marked with the red boxes, which are organized a bit differently. At each hospital, 1 or 2 shared decision-making implementation consultants are now employed, showed in yellow here on the slide. Next slide, please. Thank you. As you probably recognize, implementing shared decision-making is a complex process with many important sub-elements. When a department here at our region begins the process of implementing shared decision-making, they begin by pointing out a shared decision-making team in their own department. Then the leaders of the department receive a 3-hour course by our teacher from the Center for Shared Decision-Making. Then the pointed out teachers from the department have a 2-day course in how to teach their own colleagues shared decision-making. And then afterwards, they will have that teaching sessions with their colleagues. The department may use decision aids that are already made or develop their own. Let's talk more about decision aids. Next slide, please. Translating existing international decision aids to Danish is not always an option. Moreover, starting from scratch on your own, you'll be at risk developing decision aids that do not meet the international quality criteria. They're called IPDAS criteria for patient decision aids. Therefore, the Center for Shared Decision-Making decided to develop a generic template for a new Danish decision aid that could be used as a building platform and which can be adapted to a wide range of specific decisions. We call it a decision helper. The Center for Shared Decision-Making has been developing and testing decision helpers for the last 7 years in collaboration with the staff of the design school, together with clinicians and patient representatives. And we have published a large number of papers showing positive results of using the decision helper. Next slide, please. And here you see some different decision helpers generated from the same generic platform for use in different decision-making situations in oncology. We use the decision helper during the consultation. Next slide, please. Let's go into a little bit of detail and have a look at the individual elements in the decision helper. Step 1 presents the purpose of the decision helper and outlines the content of the decision-making situation. In this case, adjuvant radiotherapy after breast cancer. Moreover, it is also here clarified how far the patient is in making a decision about the current health situation. Some patients may not at all have considered the options, and some patients will already have made a decision. Next slide, please. Step 2 defines what the decision is about. The patient is informed about which treatment options are available. No treatment is also an option. It is also asked how much information the patient wants, hence how involved in the decision the patient wishes to be. And that's really important because some patients do not want to be involved at all. Not many, but some feel like that, perhaps especially elderly patients. But for most patients, it makes sense to be involved in the decision. Yes, next slide, please. Step 3 is about identifying what matters to the patient. Patient preferences are usually the difficult step for the clinicians. The patient is asked to relate to a question and some answers. It is important that the questions are used as an opening to a dialogue with the patient and that it will be clarified and discussed what is important to the patient and what concerns that patient the most. In this way, it becomes clear to both the patient and the clinician what personal values and attitudes are to be taken into account when making a decision, and what benefits and disadvantages are the most important for that individual person. Next slide, please. Step 4 consists of separate inserted cards with the options that the patient is facing. Each card presents the pros and cons of a specific option. Next slide, please. There must be one card per option. In this way, you can compare benefits and disadvantages side by side within the available treatment options. No treatment is also an option, as here, where no radiotherapy may lead to no side effects, but also decreases the chance of staying cancer-free. Next slide, please. There may be cards illustrating statistics. Here, statistics are shown of the risk of lung cancer after adjuvant whole breast irradiation after breast conserving surgery for early breast cancer. Next slide, please. A separate card with authentic patient stories or thoughts from other patients who have been in the same decision situation is mandatory in the decision helper. The idea is that these cards invite the patient to think about what pros and cons matters to them. Next slide, please. The final step in the decision helper is where the decision is made. It is asked whether the patient is ready to make a decision or whether more time or more knowledge is needed. Next slide, please. We believe that high-quality decision helpers are strong facilitators of shared decision-making. That is why the Center for Shared Decision-Making has developed this template called the Decision Helper that clinicians can use to develop decision aids for their own clinical context. The healthcare professionals are provided access to an online building platform from where new decision helpers can be developed. They are offered a step-by-step guidance to build and print individual decision helpers, making it intuitive and easy to work with. The template is also available in English. Next slide, please. Developing a new decision helper is not done overnight. It should take place in several steps, ensuring that both patients and clinicians take part in the development process. This involves a workshop with patients and clinicians, tests of the decision helper, and most often rounds of adjustments. Next slide, please. So how far have we come with this regional implementation of embedding shared decision-making as a culture in the region of Southern Denmark? Here's our implementation process in numbers. We started the regional implementation in 2019. As you may see, it says that only 16 oncologists have been trained in the Teach the Trainer courses, or Teach the Teachers courses. However, before 2019, the Center for Shared Decision-Making was embedded in our Department of Oncology, so all the oncologists there have already been trained in shared decision-making. The Center for Shared Decision-Making started in the Department of Oncology. Next slide, please. So that was my presentation. I would just like to say thank you so much for your time. Do you have any questions? I'll be happy to answer.
Thank you very much, Stina. That was an excellent and a really crystal clear presentation on shared decision-making. And actually, we do have a question for you already. Is there a way to edit the video that we showed, or in order to translate it to other languages? I think it may already be in a few languages, but could you let us know about that?
The video is available in German and Norwegian and Danish, and I'm sure it will be possible to edit it to another language. The center can definitely help with that. Yeah.
So if people are interested, could they contact you?
Yes.
Okay, that's great. I also like the way that you have provided simple, very understandable graphics to show percentages and statistics and that kind of thing. So excellent. Thank you very, very much. Now, with that excellent presentation, that's a great segue into our panel discussion, the first panel discussion of the day on the subject of informed consent. And let me just introduce you to the various people who will be on the panel discussing a number of questions, including questions from the audience. So first, we have Csaba Degi, President-elect of the European Cancer Organization and Director of International Psycho-Oncology Society. We have Teodora Kolarova. She is a member of the Patient Advisory Committee at E.C.O, and she's Executive Director of the International Neuroendocrine Cancer Alliance. We also have on the panel Patricia Adzkowska. She also is a member of the Patient Advisory Committee at E.C.O. And we have Andreas Charalambos, who you've already been introduced to as president of the European Cancer Organization, and he's also co-founder of the Cancer Nursing Fund. We also have Niccolò Battisti, who again is the co-chair of the Inequalities Network at the European Cancer Organization and an oncologist at the Royal Marsden NHS Foundation Trust. So I see that all the panelists are here. And I think we may remove the list. That's great, so we can see you all. Csaba, we'd like to ask you the first question. As I said, you're the director and secretary of the International Psycho-Oncology Society, IPOS, as well as a board member of E.C.O. And you were also involved in the creation of the European Code of Cancer Practice, which I mentioned at the beginning of this webinar, where shared decision-making is one of the 10 rights that all cancer patients can expect to have. So in your opinion, how can the right of shared decision-making and the right for cancer patients to be given information about their disease and treatment from medical teams and other reliable sources be better implemented and put into use in Europe?
Thank you so much, Katie. I'm very glad to be on this panel today. And I think that's an important discussion that we are opening up. And of course, coming from my background in psychosocial oncology, I would like to highlight, first of all, that we need to consider in the implementation of shared decision-making all the psychological aspects of the system of the person, affected by cancer. So I think on the psychological aspects, the first thing is we want to make sure that all the barriers are addressed that are preventing the patients from fully participating in shared decision-making, and also understanding, the options they have in treatment, the options they have in sharing the information, understanding the information. So sometimes the barriers are very, very well known in the area of psycho-oncology. They are usually the cancer distress spectrum, which anxiety, depression, fear, and sometimes I also have to say that the cultural and linguistic barriers are also acting sort of psychological barriers, because they are having their impact more widely on the functioning of the patient and the family. So first of all, I would address the psychological barriers. And second of all, I think the psychological support, the inclusion of psychological support of cancer care is also a very important element in implementing shared decision-making. I think provision of counseling, therapy, support groups, and all other resources that are making psychological functioning possible are very important, because shared decision-making is not something without the client, as we have heard, or without the context of the client that he or she is coming from. Also, I think it's very important from my experience to include the patient's family members or the next important persons in their lives in the decision-making process, because the family members or the caregivers, most of the time, they have very clear insight on the patient's preferences, values, and sometimes they also know the best how to provide the emotional and the practical support that the patient needs when it's ready to make decisions regarding, the situation that we are dealing with, cancer together. Also, I think the aspect of inequalities should be addressed as part of shared decision making, because we want to make sure that everyone, and I say again, everyone, regardless of their background, has access to the same opportunities to make informed decision about their treatment, about their personal lives, about their work status or any relationship status. So I think inequalities are also embedded in the availability of of these oldest documents and information in multiple languages. And I think this is why the question was very important questions related to the video, because I think the multiple language support is also fostering shared decision making, and also I think the cultural competence training of healthcare providers is very important. And sometimes when we are talking about inequalities in shared decision making, we are also talking about very highly targeted outreach programs of education, for example. And again, the main idea is that we should consider the psychological aspects, barriers, support, also the context, the psychological and social context of the client, including inequalities, language and cultural competencies. We should consider it as part of the shared decision making, because I think that's not a secret. I think it's, for many of us, it's an experience that cancer and its treatment is a significant has a significant impact on our mental health. And I think that's why shared decision making, it's not just about information, it's also about the way we are coping with the information, about the way we are processing information. And I think that's not a solo business. Usually it's a thing that we have to, or most of the time we do together with the system of the family system, the provider system. So I think it was a very great example that we heard, because it also included training provided and education provided to the healthcare providers in this center of shared decision making in Denmark. So I would stop here for now, but I think all the information that we heard, and thank you again for bringing your example to our meeting, are very important, because we heard about standardized patient decision aids that are helping, in taking decisions. And of course, maybe we will have time to talk about the macro level of encouraging governments in
okay. Thank you, Csaba. I'm glad you brought in the caregivers, because yes, the family are an important part of the team in this collaborative partnership with their healthcare professionals. I'd like to move on to Theodora. You are an experienced patient representative and you're a member of the E.C.O Patient Advisory Committee. So what are your perspectives, Theo, and evaluation of the current shared decision-making process?
Thanks so much, Kathy, and thanks to E.C.O for the opportunity to join this discussion, which is on a topic very dear to my heart. I do believe that when an expert, a medical expert, and a medical team and a patient and their family discuss the options in managing the disease, there are actually at least two experts in the room. Because as we saw in this very impactful video, it's you who are the expert at being you, right? So we definitely need to respect that, and we need to understand the value and the importance, the huge significance of an honest and a constructive dialogue between the medical teams and the patients and their caregivers. Just thinking of where we stand, I'd like to refer to recent research from the Cancer Research and Treatment Organization City of Hope, published just in December last year in the Journal of the National Comprehensive Cancer Network. It finds that only 30% of neuroendocrine cancer patients with advanced disease say that their top goal for treatment is living longer. So that actually busts a myth, right? The remaining patients selected other single specific treatment goals as most important, such as maintaining the ability to do daily activities, reducing or eliminating pain, or reducing or eliminating symptoms like fatigue, for example. Almost 67% of those surveyed agreed with the statement, I would rather live a shorter life than lose my ability to take care of myself. And 85% agreed with the statement, it is more important to me to maintain my thinking ability than to live as long as possible. However, respondents felt that their doctors were more singularly focused on extending overall survival, even if it impacted other outcomes. And it's a huge concern that half of the patients perceive that they did not share the same treatment goals with their physicians. I think these facts and figures speak quite loudly about where we stand.
They definitely do, yes.
Yeah, so obviously what we need to do is foster really an honest dialogue with all patients when it comes to treatment goals and priorities and various health outcomes. We need to embrace the challenge that the traditional dogma that patients just want to live longer is no longer valid.
Yeah.
And the medical teams do need to understand and respect patients' desires in order to achieve really a personalized plan of treatment that works for the patients, right?
Right, absolutely. Thank you, Teodora. And before we move on to Patricia, I just want to mention we've just heard that Bulgaria has passed a new national cancer plan today. So thumbs up, right, for that. That's
thumbs up, yeah.
Okay.
Yeah. It's a good
That's
step,
great.
for sure.
Now,
thank you for mentioning it, Kathy. I knew
that's
you were
okay.
pressed for time.
Okay, thank you. Patricia, hello. You're based in Poland and you are a cancer patient yourself. You're a psychologist, you're an experienced patient advocate, and you're a member of the E.C.O Patient Advisory Committee. So you have actually 4 perspectives of the cancer journey. And what would you say is the most important aspect of shared decision-making and information provision that you've experienced on a personal level, perhaps, or heard about from fellow patients? And I have to ask you, because we don't want to run out of time for all our panelists to be brief in your response, but we're very interested in hearing your perspectives.
Sure. Thank you so much for having me here and for these questions that, from my perspective, covers a few very important components of the shared decision-making process. So we need to remember that the most important element is patient, right? So patient must be always in the center of everything, and we always talk about that we should let every conversation should be with patients and not about patients. So regarding shared decision making, it should be exactly the same, because patient has the right to know everything about one's diagnosis, health condition, options, treatment, etc., and to decide with whom those information can be shared. So it is actually a matter of decency to always inform patient and talk to patients. So I would say subjectivity is one of those aspects, and another one, but equally important, is communication, because information are communicated by healthcare professionals, by doctors, nurses, technicians, other specialists, and we have to remember that patient is not a medical specialist and should not be treated as one. So that means language level of advancement, used words should be adjusted to patient. Message should be clear, easy to understand, and everything should be explained, question answered, doubts clarified, and concerns heard out. And this conversation should be private, with audience limited to required minimum, in atmosphere full of patience, understanding, and empathy. And those all information and options should be presented and explained. And from patient perspective and my own experience, it is really good to get prepared prior this conversation. So write down all questions, go with family member, even record the meeting if we are scared that something might slip off. But of course, by first telling doctor and get consent for this action. And last thing I would like to mention is control. In the moment of cancer diagnosis, the whole world stops for a moment for patient. And there is this feeling that I don't have control anymore. Cancer is leading my life and there is nothing I can do about it. So involving patient in every step helps getting this control back, because it is not true that cancer is a boss here. Not at all. Patient is the boss. And so making decisions and being involved, being asked and informed for patients, it may equal to having control. So, and with this control comes power, engagement, and strength. So I would say subjectivity, communication, and control are the most important aspects.
Excellent. A very good trio to remember. And I think, Stina, you might have a future consultant on the next film here for you to work with, because she's come up with some great tips. So yeah, thank you very, very much, Patricia. Really appreciate your involvement here. So Andreas, I'd like to turn to you now as president of E.C.O and a co-founder of the Cancer Nursing Fund. And you're also an executive board member of the European Oncology Nursing Society, EONS. So what, in your opinion, is the role of the oncology nurse in the process of shared decision-making? And again, I would ask you to keep it as brief as possible so we have time for some audience questions as too. Thank you.
Thank you so much, Kathy. I'm sure everyone agrees that we have heard many views during this webinar that brings and shed light to this important topic. Moving on to oncology or cancer nurses, nurses are an integral part of the interprofessional team. As such, they work with patients and families to provide integrative, cohesive answers to specific questions at key junctures. And at the same time, they facilitate the development of strategies that implement and support informed decision-making with the patients and their families. So nurses within the clinical context, they can assume various roles that can support informed and shared decision-making by empowering patients and their families. I have limited time, so I will be mentioning only a few. So having said that, nurses can act, for example, as decision coaches. This is a non-directive support to help patients and family actively making decisions about their health. Nurses make for excellent decision coaches, given, for example, their frequent contact with the patients. Specifically, they assess patients' decisional needs, tailor decisions, supports to match them, and then monitor and facilitate progress in how decisions are implemented. But also nurses can be patient advocates. So the nurses training in nurse-patient relationships emphasize the importance of patients' perspectives, values that we have already mentioned, and preferences. This training, when it's complemented with the principles of whole person care, which is second nature to nursing, it makes and enables nurses to practice this routinely, and at the same time, it enables them to help patients integrate complex cancer care information with personal preferences. And we shouldn't be forgetting that a cancer nurse is an ongoing liaison acting between the patient and the family with the rest of the members of the interprofessional team, conveying their decisional needs and preferences to the rest of our colleagues. And I will stop here due to time. Thank you.
Thank you, Andreas. That's a very helpful summary. And I know the audience appreciates that and your insights. Now, finally, I'd like to turn to you, Nicolo, because you are very interested, I know, in improving cancer literacy. So, of course, you are convinced of the benefits of shared decision-making and patients receiving all of the relevant, reliable information about their disease. But do you think that there are certain barriers to achieving these things, perhaps with some healthcare professionals? And again, if you could give us a brief summary, that would be wonderful. Thanks.
I will. No, thank you. But thank you very much, Kathy. I think we had an awful lot of wonderful, really tips to really improve this aspect, which is to me as a clinician still very much an unmet need, unfortunately, in healthcare systems. I would say that at the practical level, one of the key considerations, one of the key barriers is really time, staffing, facilities. Do we have enough resources to actually facilitate shared decision making? Do we have rooms? Do we have spaces? Do we have really also time to involve and empower patients with these discussions. I think I would really like to highlight the excellent work that has been done here in England, for example, in terms of shared decision making, with some by the Commissioning for Quality and Innovation. If you look at the website, the number 11 Sequin project is actually focused on improving high quality shared decision making conversations in specialized pathways, such as, for example, oncology. So again, hospitals are being supported to actually achieve shared decision making, more and more shared decision making with our patients. We know that this is something that we can also measure, we can also score, we can also benchmark. And for example, again, my hospital as well is taking part into this project, and that is obviously supporting our time, our resources, our spaces to really achieve this goal. Second aspect, which I think is very, very important when it comes to improving our practice, is also training, education. Do we really train enough healthcare professionals, including medics like me, in the value, the benefits of shared decision making? Do we provide them with the adequate skill set to achieve this in the consultation with patients? One of my interests alongside breast is geriatric oncology. I think the management of cancer in older individuals is a very good, let's say, setting to study, investigate, and demonstrate the value of shared decision making, because obviously we are dealing with sometimes much slimmer benefits of cancer treatment decisions, balanced with potentially increased risk of side effects and complications. So there was a wonderful study that was published in 2020 in JAMA Oncology by Supriya Moile, one of the brightest minds in the field of geriatric oncology, demonstrated, for example, that if we integrate the geriatric assessment in routine care of older patients with cancer, we can improve shared decision making, we can improve satisfaction of patients and also their caregivers with discussion that we hold routine in the clinic. And why is that? Because with this assessment, for example, we can capture more systematically what matters to patients, which is obviously what we were discussing earlier during the webinar. And I would really like to finally to highlight one of the key aspects that Stina also mentioned in a beautiful talk. This is something that makes me also more confident in issuing my treatment recommendation with patients. So if I manage to empower the patient and really have discussion with the patient on the same level, me as a healthcare professional advising the patient what is the evidence available, alternative treatment options, pros and cons of decisions, that's something that would also give you more confidence in recommending in favor or against specific treatment option. So yeah, these are really the three key aspects that I wanted to highlight. Again, we need healthcare systems that are more attuned to facilitate shared decision making. We need more education, and this is really a big thank to E.C.O for arranging today this meeting. And we need also to remember as clinicians that this is something also that supports our routine clinical practice. Thank you.
Thank you, Niccolò, for summarizing that so well and so succinctly. I really appreciate that. Now, we have just a few minutes left in this part of the session to have some questions from the audience. So I've got some here, but please do keep your answers brief because we want to cover them as much as we can in the next 5 minutes. Now, the first question is from Stefan Geisels from the Belgian Patient Expert Center. And he says, I think it's also critical to involve patient organizations to help understand the real needs that are not addressed during the formal discussion. Any thoughts on this? And we know this is not Stefan speaking, this is me, but we know that there are certain things that patients take away home with them without having discussed issues in an appointment. And particularly Theodora and Patricia, do you have any thoughts, really brief thoughts on the role of patient organizations in this shared decision-making process?
Thanks, Stefan. That's certainly a great question. And I do think that there is an instrumental role that patient organizations can play here, not only by advocating on a general public level, if you like, but also networking and working very closely with the healthcare professionals and the teams in the various disease areas that we operate in. I think that that's the only way that we can actually make sure that we speak the same language, and that maybe some barriers or taboos or, you know, hot potatoes in the discussions for various reasons, be that cultural barriers or, you know, just the lack of enough time to go in depth enough, are really addressed and taken into consideration when thinking collaboratively and really sharing the process of decision making.
Okay, thank you. Now we have another question here. What about shared decision-making with childhood cancer, different age groups, for example, teenagers? Can they be involved together with their parents? From which age do you think this is possible? And Andreas, I wonder if you have any thoughts on this. Do you see children in your day or young adults in your day-to-day work? Yeah, teenagers.
Well, it's a very interesting question, and I would say that of course we do have to include children or young adults in the decision and in the informed shared decision making. As I mentioned during the response to the initial question, is that we treat and we engage with the persons, and those persons include also the parents and the children. And I would say that depending on the children, we can involve them based on the needs and the preferences of the family as a whole. But most definitely, we should be engaging with them in this informed shared decision making, because it's based on the ethical principle that no decision should be made for them without them, and this applies to absolutely everyone.
Okay, well, thank you for that. This whole issue of shared decision making, it's really very much a team effort, isn't it, between the family, the patients of any age, frankly, and the healthcare professionals. And I hope that message has come across today. I think it has. We are out of time for this session, but I want to thank you very much, one and all. It was a really useful discussion, and I hope you, the audience, have taken away some really helpful tips and interesting information, and that you feel better informed about shared decision making too. So we are now going to move on to part 2 of today's meeting. And I'd now like to introduce my co-chair for this webinar, Dr. Guy Buyens, who is the medical director at the Anti-Cancer Fund. So over to you, Guy.
Yes, thank you, Katie. I had a small technical problem, but that's solved now. There can be no shared decision making if patients are not informed. So after this first session on shared decision making, we now want to focus on patient information. And we start with a presentation of Gabri Kuiten. Gabri is the coordinating physician of My Cancer Navigator, a free personalized information service of the Anti-Cancer Fund. So Gabri, please introduce us to My Cancer Navigator.
Thank you very much, Guy, for this introduction. I appreciate the opportunity to present My Cancer Navigator here. The slides can move, maybe? Yes. So what is My Cancer Navigator? As Guy mentioned, it's an information service for patients or their relatives or loved ones that is independent from any government organization or healthcare institutions. It's evidence-based information that we provide, which is personalized for the situation of the particular patient, explained in understandable language, tailored to the person who is concerned, and it is free. And what we aim to do is support patients in the informed and shared decision-making process. Now, the service is also available for healthcare professionals who wish to explore additional treatment options for their patients, for example. Next slide. So why do people need this service? I think many of these aspects have already been addressed in the meeting so far. Oftentimes there's not enough time during a consultation to address all the questions needed. Sometimes people are hesitant to question the doctor, criticize the doctor. There is a perception of also an actual power imbalance oftentimes where the patient feels intimidated. Sometimes people simply need more information than what is provided. A simple yes or no question might be okay for some people, but others might want more background information on why a particular treatment is or is not recommended. Then there's various communication barriers, the use of jargon and lingo, the terminology, like Patricia also mentioned. It's not okay to use that with many people. Emotions, of course, can get in the way. If people feel overwhelmed, they cannot absorb information, and there can be simple misunderstandings like in any conversation. Outside of the consultation room or outside of the hospital, there's also an abundance of information out on the internet from friends and family that is often confusing, conflicting, and sometimes outright misleading. So that is also an area where we support patients to clarify what's what. Next slide. So we provide the information to patients on treatment options, which could include clinical trials as well, where we really manually go through all the potential trials to see if people might qualify for them. If people are seeking a center of expertise for their particular cancer, or they're considering a second opinion, we might give suggestions for this. And we also provide information on non-regulated therapies if people ask about them. Our work is always guided by the patient's questions, and we are very strict on not giving any advice. We will provide the information on potential treatment options and then recommend the patient discuss those with their doctor if they want. We will not say what's what and what's best for that person. Now, and of course, this is complementary to the more general information services that are also excellent and available in many countries. Next slide. So the way it works, we start in the left upper corner here, where the patient can contact us either through the website, through an email, via a phone call. And the next thing that happens is that one of our physicians, one of the My Cancer Navigator physicians, will have a call or a phone call or a video call with the patient. We try to understand what the story is, what type of cancer they have, what treatments and tests they've already had, and what their questions are. And we also go a little bit more in depth. Why does a person maybe not want chemotherapy? Why is a person asking about some particular side effect? We also explain how we work, of course, and then we ask that people consent to our privacy policy and sharing their medical records that are relevant for the search. And then we proceed, and one of our research managers will then do a structured, very detailed search online. Depending on the question, we will consult clinical trial databases, we'll do PubMed and Congress literature searches. We will look into international treatment guidelines, and based on all the information that we find, we create what we call a work document that is then discussed in our team meeting. And we have a weekly meeting where also oncologists, one of whom is Nicolo, that you just saw on the panel, will also give their input from a clinical perspective, what might be relevant to the patient. After this, we write a summary for the patient in understandable language, where we also do include all the references and links to the relevant trials, etc., so that if the patient or their clinician wants to look into that more in depth, they can see where we get the information. After that, we have another call with the patient to go over the information, answer any questions they might have right away, clarify things. And then if there's more questions, either immediately or at some point in the future, when there's maybe another decision to be made, we can start over again and support the patient again. As mentioned, this is a free service, and the Anti-Cancer Fund provides the resources and the people, of course, based on donations. Next slide. This is our team. I will not name everyone who is here, but it is important, I think, to know that we have, on the one hand, our physicians who are in direct contact with the patients. Then we have 4 scientists who do a tremendous job of doing all the searches that are pertinent to the questions. And we have external clinical specialists who give their inputs based on their clinical expertise. And Nicolo and Sergio are with us every week, and others are consulted as needed based on the type of questions that we have, the type of illness. And then, of course, Guy, who you just saw, is our medical director who supervises the service. Next. So I just want to briefly show you what we did in 2022. We supported 325 individual patients, most of whom, in the next slide, you will see were adults with a small number of patients, children, and about 60% of patients we supported were female, the remainder, of course, male, and mostly in 60% of cases, it was the patient themselves who contacted us. In other situations, it could be a relative or sometimes also a healthcare professional. It is important to note that if there is a contact person for the patient, we do still request the agreement and the consent of the patient themselves, obviously, to speak about their situation with that person. Next slide. We do, I think maybe there's another click needed, or there's something that went wrong. No, I'm sorry. Okay. The colors are not showing the way they did on my computer. But anyways, we do support people all over the world. We're based in Belgium, so about 45% of patients that we support come from Belgium, followed by the UK, the US, the Netherlands, and France. But as you were supposed to be able to see, we do support patients from all continents worldwide, as long as they can communicate in English, French, or Dutch. Next. Here you see the types of tumors of the patients we support. Now, as in society as a whole, gastrointestinal tumors, breast cancer make up a large portion of those, but we do have a disproportionate number of brain tumors and sarcomas and other rare cancers. We believe this is because this often concerns young people, and there are very few treatment options. So people tend to really go look for information, maybe more so than for the more common cancers. And next. And these are the questions that people have asked. There's more questions than patients because most people have more than one question, obviously. And you will see that in general, it's about treatment options, whether it's a specific treatment option, something that has been proposed or something that they have heard of, or just in general, what if my next scan is not good? What options do I still have? Are there any trials for me? And then less frequently, people ask about side effects or specific questions about their disease, for instance. Now, next up, I would like to share a testimonial. The lady you will see in this video is Sean, and go ahead.
A nurse at a local cancer charity put me in touch with you. She said that you offered an amazing service where you would look at something objectively from the medical perspective and offer a really good overview of what the best practice treatment would be, regardless of what my local hospital might offer. So it was very clear what you asked. So you wanted to have my scans, my bloods, and my clinical letters, so that you could make an informed judgment. So I think you did two things. One is you gave a lot of time in a video link and explained things. And the other thing was you then consolidated it all in a letter, which was really helpful. So I didn't have to take any notes. I could just absorb it and listen. So, because you have very little time in an NHS practice, you don't want to ask red herring questions. So what's good is to get out all the red herring questions, all the questions which aren't necessary to ask, all the blind alleys online with you, so you can actually understand the actual key questions to ask. I guess having a conversation with you is helpful to understand that you're not just a patient, you're also a person. It reminds you of that, so you can take that in, that protection into a consultation room. Maybe it's helpful to do your research if you're a patient in just one or two places and not look things up randomly. But also, I think maybe the patient needs to decide what kind of patient she is. Because she might not be someone that wants to. She might just want to be told what's happening next. My experience is the best clinicians are clear and use clear language and are not fazed by a patient being upset. If you allow a minute for the patient to be upset, actually it makes it a lot better for the patient, I think.
Yes, so that was Sean. We've been in contact with her for quite a while already, on and off, and she agreed to have a video chat with me. Now, next, there is Mason, who you see here. I also had a video chat with him, but the quality turned out not to be sufficient to show here. So the link to the video, though, will be shared in the chat, and I do encourage you to look at it. It's very inspiring, but I do want to just mention his story briefly. Mason is 19 years old, from Iran, and he contacted us last year when he was 18. Because he has had neuroblastoma since he was 6 years old. And he has had many different chemotherapies and surgeries, and had now arrived at a point where his doctors in Iran were saying, well, if this chemo doesn't work anymore, we have nothing else to offer you. And so he started searching and found My Cancer Navigator. And of course, it's a very difficult situation. It's a difficult disease, but we did look into potential clinical trials, potential treatments. We, explained it all to him and encouraged him to discuss with his doctors, to maybe reach out to centers internationally, or we also offered our support to do that. We didn't hear from him for a while after that, but then 6 months later, he contacted us to say that he had found a trial and got a center in the US was willing to support him also financially, to obtain a visa, etc. And he is still participating in the trial and doing well. And We've done very little. He did most of the hard work himself, but he did get this little push to explore additional options that had not been open to him before. So please watch the video. It's about 4 minutes. It's not great quality, but the message does come through loud and clear, I think. Thank you all very much for your attention.
Thank you, Gabriel. So we now have time for questions, and we will start with our panel. And Nicolo, first, I would like to address a question to you, because you're also involved in My Cancer Navigator. We often see a different perception when people reach out to us between the treating physician who thinks that the patient is well informed. He thinks that he's done a good job, but then on the other hand, the patient who clearly is in need for much more information. And why you think this gap exists?
Thank you, Guy, and thank you, Gabriel, for the fantastic presentation. I think shown in a video, the patient testimonial highlighted a key problem, a key challenge, which is the same that I discussed so previously. Time is the most important resource that we have in healthcare, isn't it? I guess if we haven't got enough time to discuss, to provide patients with information and to have a very open, detailed discussion, then that's when the gaps in what we think that patients know and what they actually know exist. Gabriel also mentioned that there is also the relationship between a healthcare professional and the patient is also imbalanced, and that's because the patient is the patient, the healthcare professional is the person advising on the management of the patient condition based on the available evidence. And sometimes that can generate a risk of sometimes not having a very open discussion with the patient about pros and cons, about alternatives and so on. I think it's also very much a cultural aspect. I have worked in 3 different countries in my career, and I've seen very different approaches sometimes, also based on specific countries. We should always remember as clinicians that we are, again, professionals advising patients on the management of very delicate condition with potentially vast implication on their well-being and their life. So I guess we should always remember to provide them with the full set of information. But again, if we haven't got the time to do that, then that becomes really a challenge, because we also need to translate the evidence available that we are deriving every day from clinical trial, registration trial, and so on, in words that patients can actually process and understand. Sometimes there are also some misconceptions, not only from the part of healthcare professionals, but also from patients and their family. Sometimes I hear, "Oh, you in the clinic, you tell me what I need to do. You know it better," or "Do I really have an alternative?" And I always like to highlight that yes, you do have an alternative. You do have the option of saying, "No, this doesn't feel right for me. I would like to try something else," or "I know it better because, again, I am the patient and I know my body, I know my mind, I know my expectations, I know my concerns much better than you." So it's a very difficult process, and this really is a shout out to the Anti-Cancer Fund and its work in really personalizing also the provision of information is absolutely crucial, especially when it comes to cancer care, because again, patients may have different views, different concerns, and they may also, like Sean mentioned, wish to know everything, every single detail and figure, or maybe get some information, but not the full extent. So I think the first question that I tend to ask patients in the clinic when I see them for the first time is really, what have you been explained so far? What do you know about your condition? What's your understanding? And that really guides me a lot on also how what the type of information that the patient would like to get, and also in what way. We do have those of you that look after patients with breast cancer. We do also have access to prediction tools that can tell us what is the survival benefits of, for example, pursuing a specific systemic treatment options for patients with curable breast cancer. There are some patients that may be very interested to know those details as well. Patients that may actually know, they may find actually not very useful. So it's our job as a professional to really understand and how we can best personalize not only the management of that disease, but also the provision of information that obviously we carry out in the clinic. And I guess to me that's one of the key things to remember in the clinic as a clinician. And I think that sometimes, as you say, Guy, really the reason why sometimes there is this big disconnect, this big gap in what we think the patients know and what they actually have processed and have gained, have received during the consultation. Thank you.
Thank you, Nicola. You also made the connection with the first speaker, actually, is that the patient himself or herself knows best what's going on, and that has to be taken into account. I think it's a very important concept, and it was stated in the first video, which I liked a lot, to introduce the shared decision making. Andreas, I want to come to you now. So we heard about the My Cancer Navigator service, which is really more focused on treatment, scientific information for shared decision making, but there are other information needs, often much more practical. And there's also a question in the audience, as I saw, and that can be covered by, for instance, the oncology nurse. However, we hear that in many countries there are just not enough resources to provide oncology nurses for all patients. So we have this dilemma. We also heard from Nicola that resources, time is of essence. But from a nursing perspective, can you comment on that?
Thank you so much, Guy, and many congratulations to Gabi for an excellent presentations, and the testimonials that were great and to the point. So coming back to your question, Guy, as we already heard, shared decision making is complex, and it's a process that involves multiple stakeholders in healthcare systems. And a pivotal role is played by the cancer nurses, and this role extends to include the whole span of the cancer care continuum. So shared decision-making is underpinned, for example, by the practice of person-centered care. Therefore, for example, when there are not enough resources, and we're speaking about understaffing, for example, this might threat the ability or the breadth that the nurses can practice this approach to care, therefore impacting negatively shared decision making. In a very recent systematic review by Waddell and colleagues on the barriers and the facilitators to shared and informed decision making, it was revealed, for example, that one of the dominant themes was related to the challenges faced by clinicians, including nurses. And these challenges were directly related to the fact that there was not enough space and time for them to practice shared decision making. And another systematic review by Grevel et al. also shed light on the clinician's perspective and showed that the lack of resources, such as understaffing, as we mentioned earlier, can also impact on the motivation of the interprofessional colleague to practice shared decision making. But we speak about practices, we speak about resources, we speak about the availability of professionals that could facilitate shared decision making. But it's also about the culture of the organization where healthcare is being delivered. And issues such as limited resources can directly threat that culture of supporting, facilitating, and implementing shared decision making. And due to time, I will stop there, Guy, and allow some time for the other panelists. Thank you so much.
Thank you very much, Andreas. I want to change the topic a little bit. One of the motivations for the Anti-Cancer Fund to start with this kind of service was that we were confronted with very unreliable information to patients and that had devastating impact. And Patricia and Theodora, I want to ask you, we all know the danger of misleading information and pseudoscience. However, there are also a lot of good, reliable resources and services available for patients and their caregivers. But how can we help patients and families to find their ways to trustworthy resources and services and protect them? So maybe Patricia, you go first now, because Theodora was first before.
Okay, thank you. This is like a really tough subject, and it shouldn't actually be one at all. I wish everyone would believe in science, evidence, research, and medicine, but I think pandemic shows us how dangerous pseudoscience is. Of course, it existed before, but during those past 3 years, scale of this phenomenon simply terrified me. All of us, everyone who is here today, I believe we are doing a great and very necessary work, and we have to keep just doing and keep pushing, support each other, and understand that we have common goal, so patients' well-being, and common enemy, which is cancer. From patient point of view, another patient's perspective is extremely valuable here. So it should support patient organizations as much as we can, because they have community who share experience and knowledge among each other, have some amazing projects, and produce a lot of useful content, which is easy to understand, clarified, and on point, and that is translated to multiple languages. Patient organizations work with healthcare professionals, involve them and their perspective in actions, so we should spread the word and share reliable informations, but always check sources and keep learning and actually never stop fighting. Because I can say from my own experience, when I was diagnosed with cancer and had already histopathology in hand, I've tried to look for some information online, and my mom also tried to, and she found some scientific publications, but they were all in English, and she doesn't speak that language at all. And hours later or days later, she found one article in Polish, which was based on a research study of 6 Polish patients with same diagnosis as mine, which gave her some perspective. But at the beginning of her research, she hoped for much, much more. So we can try to show this issue and discredit lies and some misleading informations, but we also have to be very careful, because no one ever changed mind just because of an insult. So the discussion has to be on point and based on facts, but also kind and full of empathy, because pseudoscientists prey on the misfortune and tragedy in fulfilled promises and the last light of hope. So if medicine is helpless, area for pseudoscience opens. Facing cancer, people look for the last resort, and we as patient organizations should be this linkage between evidence-based medicine and science and patients and caregivers who look for help and support. So every action we take must be full of empathy and understanding. And all that research shows we should pass on in a way that would be most appropriate for a particular situation.
Yes, thank you, Patricia. Very, very good information. Theodora, do you have something to add?
Well, I fully echo that. It was well, brilliantly articulated. Thanks so much for doing that, Patricia. just maybe briefly add that, as we all know, information is power, knowledge is power, and what we can do is, again, collaboratively raise awareness among our communities that medically vetted, valid information should be sought, and also make sure as patient organizations, but also as healthcare professionals, that we speak the patient's language, that we write and pronounce information that's really understandable, and that we can overcome not only the language barrier, but also the perceptions barrier, if you like. And again, I want to echo this word empathy, which both Patricia and Nicolo mentioned, but it was also one of the, I think, most powerful messages in Sean's testimonial. We need an honest and human dialogue between the medical professional and the patient. We need the medical profession to understand holistically the patients and their lives, and we can only take it from there. And as Patricia said, really wedding evidence-based to what matters for me now and what would matter for me 5 years from now is, I think, what we should be after together as a community. Thank you.
Yes, thank you. Just another topic, Saba. Sometimes a patient just doesn't want to be informed. It doesn't want to participate in the decision making process, which of course it is their right. But you already mentioned before when you addressed the first question on shared decision making, and some other panelists said it also, a cancer diagnosis, the challenges, it can just be very overwhelming for the patients. But can we help those patients as well? Should we help those patients? And what is your perspective on that?
Thank you so much. I will try to be as brief as possible. Actually, this is one of the hardest questions probably that we come across in cancer care. Many years I was involved in the psychosocial effects of the cancer diagnosis non-disclosure. That was an issue in my country for many years, and probably in different cultures, for different countries, it's still an issue. And of course, I fully agree that the autonomy and independence and empowerment of the patient are the most important things. And as we heard from Denmark as well, there are cases when patients do not want to be part of the shared decision making. But most of the time, if we keep out the patient or we just keep in the family members and keep out the patient, it is also a possible situation. Then the feelings of betrayal and the feelings of mistrust are going to be generalized towards the healthcare providers. So it can be very difficult for patients to have informed decisions about their care and treatment and about their relationships and work status. If, these feelings of betrayal and mistrust, it's generalized towards the healthcare providers. So in this context, I think that we should, of course, try the basics and also a little bit of added psychosocial support, because the basics all the time is to provide the clear and easy to understand information, because sometimes patients are overwhelmed, and are not able to process the information provided to them at once. But maybe if they are given a little bit of time and maybe an easier version of what is happening, then sometimes if they are allowed to absorb the information and ask questions, then they might reactivate and make decisions together with the team, of course, sometimes at their own pace. But again, this is the basics when we're talking about communication with our patients. But together with this, I think the provision of emotional support, it's very important, because this kind of interaction, it's a different kind of interaction, and it actually activates different patterns of collaboration in patients. So provide emotional support. I mean, emotional support, it's not provided based on the decision of the patient that they are willing to be part of the shared decision making or not. Right? So we have to respect the rights of the patient. it doesn't matter what is their actual decision, but we want to make sure that the overwhelming feeling, it's not something that it's final. We want to make sure that we can use information or emotional support as coping instruments for our patients, because sometimes when they have resources, they are empowered, and like this video is also empowering. And of course, we also, I did remember this, I did talk about this, but I would like to remember that language and culture and cognitive barriers are also important. So when the patient, it looks like it doesn't want to be part of the shared decision making, please make sure you have your own checklist, because sometimes it's not a final decision. Sometimes it's really just too much for the moment. But again, information and support, I think it's the best combination that we can get.
Yes. Thank you very much. Very well said. We do have some time to go to questions from the audience, and I would like to start with a few questions that were directly for Gabri. Gabri, one of the people asked the question, and then we discussed this many times. Do the specialists in the different hospitals accept the additional information from the Cancer Navigator? Gabri, can you comment on that? I mean, it's a question that's coming up quite a lot. So
yes, indeed. So I briefly answered it in the chat as well, but so reactions from specialists vary. Some are quite happy to see our summaries and get the information, and sometimes they will follow a potential lead to a clinical trial or an early access program for a medication, for instance. And some have even started referring patients to us, especially if there's not many options for treatment anymore. Others feel that patients should not ask anybody anything except to their doctor, and it's quite frustrating. So Julie also asked, how do we help patients to present this information to their doctor, right? Because it can be scary. So we do help them prepare the visit a little bit and say, okay, these are the questions you can ask. We make it very clear that we don't give any advice, but that there are options that they might discuss with their doctor. And sometimes they kind of find a way around it, and they say, I found something on the internet, or my son found something, and they don't really say that they came in and discussed with us. But unfortunately, that's sometimes the best option for some of the patients.
Yeah, there's another question for you, Gabri, but I think it's also a question to me. It's how do you manage to fund this fabulous service? Well, first of all, we are a fund, so we decided to provide the service for free. We started with an acceptable number. Now this number is increasing, and we have to find other ways, and we have really to look in collaboration with other organizations how to expand. We want to expand. We want to continue. We want to give it for free. So we started with the service in Belgium. We went out to the Netherlands, and then now it's in Europe. But still, we can reach much more patients. But then I think we should look at more collaboration. So it really is something that is high on the agenda, because we would like to provide this service and continue to do it for free. But Gabri, feel free to add something if you have a thought on that.
Well, maybe I can just add that right now our funding is entirely based on donations.
Yes.
Some large, some smaller, mainly from individuals, some inheritance, and also some companies, but not healthcare related companies, because we want to protect our independence. And so, yes, we do hope to expand collaborations in the future so that we can expand even further.
Yes, and if we accept money from a company, it's a purely donation. There's nothing that we do in return for that company. If we really want to be independent, which I think is essential if we want to give a service like that. There's another question that we have from the audience. Why is there no standard procedure for referring patients with life-threatening cancers like pancreatic cancer from local hospitals to specialized university centers? So yeah, I think this is a little bit beyond the scope. It's not purely on information. It's how you organize best care. Yeah, this is a topic. But maybe Nicolò, can you comment on this? You're muted, Nicolò.
Can you hear me?
Yes.
Sorry, I didn't get the question. Sorry, Guy.
Well, the question really was that there's no standard procedure for referring patients with life-threatening cancers like pancreatic cancers from local hospitals to specialized university centers. I said this is a little bit beyond the scope of
Yes.
purely information giving. It's about organizing best care, and it's beyond. But maybe there should be a good mixture between smaller hospitals where there's more time for the patient and bigger hospitals. But I think it's a little bit out of scope. But can you comment on it?
I think this is a good question. My view pragmatically is that if somebody could get a standard of care closer to home, that would be the best, the most appropriate option, because obviously treatments that we give, especially in this specific disease setting that was mentioned, can be quite challenging, quite intense, lots of appointments, lots of blood tests, and so on, potential side effects. So my view in general is that if a patient can get a standard of care when it comes to systemic treatment or local regional treatment closer to home, they should take the priority. Obviously, if there are trial options available that sometimes may be more frequently available in academic centers or cancer centers with large trial portfolio, that's a different story. But I wouldn't necessarily think that in academic centers or cancer centers, actually, there would be necessarily more time, or to actually aim for more detailed consultations. So it really depends on the the local setup, the staffing, the volume of patients being seen, and so on. There are obviously very well established standards of care for the management also of this specific condition, and if these are available in a general hospital with an oncology department closer to home, I wouldn't see anything wrong with that, to be very honest.
Yes, of course, the question came from the pancreatic cancer setting, and there you need concentration of knowledge, and we know the situation. There's another question. It's related to the shared decision-making process. How can you ensure that as part of the shared decision-making process, the patient gets an active role for her own treatment pathways and gets control over some processes, including nutrition, physical activity, social interaction, etc. So it's broadening it, and I think Andreas already mentioned it, but maybe we can now have the perspective of either Theodora or Patricia. Theodora, maybe.
Thanks, Guy. Well, I think that this boils down again to empowering the patient and listening to the patient and giving them the rights to take control of their own life, and first of all to understand the importance of the aspect of nutrition, physical activity, etc., and the impact that those parameters have on the treatment success, if you will, and the quality of life that one can have. And taking it from there, the caregiver's role is also instrumental here, because the patient is never alone in their journey. And these choices are really everyday choices that should be supported in the family environment, in the loved one's environment of oneself.
Yeah. Nicolo, I saw that you mentioned multidisciplinary. I know how you feel about the
Yes, indeed.
approach every time we discuss. So, yes, can you comment?
You know, I think that's an excellent question, an excellent comment that the audience made. We do have, sometimes we don't realize that, but we do have access to an awful lot of expertise in our institutions that sometimes it's not used as much as probably we should. So a number of important domains, the well-being of patients has been mentioned by the audience, and I think as you know very well, Guy, my view is that medics should work in close collaboration with obviously nurses, allied care professionals, pharmacists, patient navigators who are available, because the management of cancer is obviously complex, the treatments are increasingly complex, and again, we should always adopt a holistic view when managing these situations. So again, to me, multidisciplinarity is really key, and this is wonderfully reflected by our European Cancer Organization, isn't it?
Yes, it is. Yes. We come now to the end of this Q&A session, but we still have some time left before we close to have the perspective of some other stakeholders. The first one, Kilian Nicole, as head of the Health in Society unit of the European Commission's Joint Research Center, and I would invite him now to give his comments on how our concepts and ideas like shared decision making and personalized patient information reflected in some of the work you and your team conduct at the Joint Research Center.
Well, thank you very, very much, Guy. A big thanks also to the European Cancer Organization and dear distinguished speakers and panel members. It's been really interesting to follow this fantastic webinar. And all I can say is from the perspective of the JRC, and we work closely with our colleagues in Santé, DG Santé and DG Research, is yes. I mean, this is the future. So yeah, shared decision-making, personalized patient information is the only and the best way to go. And there's absolutely no doubt about that. So full support from our side. And I want to give now some perspectives from how that can resonate, let's say, in the activities we perform within the JRC against the backdrop of all the EU prioritization on cancer at the moment. Now, basically, I'm sure you all are aware, and I will just speak for 4 minutes, 5 minutes, something quite short. You're all aware of the Europe's Beating Cancer Plan, which is the biggest ever push from the public health perspective to support and to tackle cancer, which unfortunately is running out of control, and a lot needs to be done. And it's a pleasure to meet you all, and also so many participants working on that. So the public health perspective, Europe's Beating Cancer Plan, and then the DG Research perspective, the mission on cancer, both have been co-designed together. And then in the middle, you have us, the Joint Research Center. So when it comes to shared decision making and patient centricity, I just want to mention one thing, that in the Joint Research Center, basically we need to uphold independence of 3 things, basically. One, of private, national, and commercial interests. So the great thing about that is that it allows and promotes the idea of putting the patient at the center of the paradigm when it comes to any aspect of cancer, whether it be prevention, screening, diagnosis, early detection, not to treatment, post-treatment, palliative care, psychosocial care, pain management, you name it, the patient has to be at the center. So I'm going to put a thing in the chat about the Knowledge Center on Cancer, just a link, or if you want to have a look, just Google Knowledge Center on Cancer. So for the first time ever, some systems, portals, gateways, and platforms have been built within the European Union, within the Commission, and these are located in the JRC. So the Knowledge Center on Cancer was launched in June 2021, and it aims to foster this alignment and coordination of all European Commission activities and initiatives on cancer, because by working and by planning and working together, we can leverage more impact. Now, that's a bit of the background. Within that knowledge center, we have a number of activities, and I think there I can zoom in a little bit on the patient centricity part and on the shared decision-making part. You may be aware too that in June 21, we published and provided the new European guidelines and quality assurance scheme for breast cancer screening, diagnosis and care, covering the whole pathway to end-of-life care. Within those expert groups, there were 70 experts, 35 from guidelines, 35 from quality assurance. We had, of course, Europa Donna, which is the patient advocate for breast cancer in Europe in 46 countries, but also we had patients within the expert groups themselves. So a fundamental part, and it was mentioned today a number of times, was MDM, multidisciplinary meetings, where the experts like yourselves talk to each other, making sure, and the patients at the center giving the best possible advice. So what I would say is compliments to this initiative. The European guidelines are available. We are piloting them right now in 10 countries and 20 cancer settings. And so far, the results look very, very promising. Now, these guidelines and indicators are about raising essential standards, making sure the patient doesn't fall between the stools of the healthcare pathway. Essentially, that's it. Just bringing up the overall level, and in doing so, also addressing unacceptable inequalities that persist both within and between EU countries. Basically, those European guidelines are open always for new evidence. So as you're doing this fantastic work, if new evidence becomes available that can go into these recommendations and guidelines, please do submit it to us, because we rely on, we cannot do everything ourselves. Wonderful work going on. So as evidence comes available, those guidelines are updated in real time. We're hoping now through the EU for Health program to actually support implementation of the guidelines. And then we have this European Cancer Information System, which contains 60 million cases covering 64 cancer sites, which is used for monitoring and for projecting the burden of cancer in Europe. So a future plan there is to integrate indicators used for monitoring the impact of population-based screening programs. So again, that's a nice example of a marriage between the Cancer Information System and the European guidelines. Another pillar of the Knowledge Centre is the new kid on the block, the European Cancer Inequalities Registry. And we know E.C.O has the Inequalities Pulse. We want to meet together to synergize there. It's important that we all work together. And basically, with the Inequalities Network you have, I have a little request, we can handle it later. We would like to be part of that or be engaged in that, because maybe we could contribute to each other on that. Because we all want the same thing, and the patient is at the center.
I'll let Nicolo decide on that.
Yeah, that can be outside the scope of this meeting, because we don't want to take up people's precious time. But yeah, we'd be very interested in being part of that if we're allowed, because we may be able to support and vice versa. So basically, the European Cancer Inequalities Registry is now really gaining momentum. In the coming year, we want to start putting in environmental exposure indicators as well. So for example, we're advancing well when it comes to mapping radon at NUTS 3, NUTS 2 level with lung cancer, issues like that, where we're looking at cancer in the bigger perspective, and also behavioral and whatnot. So that's another area. Basically, we also have activities on prevention. So when we do identify inequities, best practices are there available. And now, I mean, the sun is shining, the EU sun is shining on cancer with so much funding available. So basically, it's a very good time between now and 2027 to trigger actions, because a lot of evidence is there, best practices are there, inequities are there, a lack of patient centricity is often there, multidisciplinary meetings, shared decision making, etc. So it's a good time to strike the iron while it's hot, or make hay while the sun shines, however you want to address it. And I think that's where also together with us in the Commission, because we support the member states. That is our mission, that is our mandate. We're not trying to build something for ourselves. Who are we? We are only as good as the sum of the member states. So yeah, I don't want to go on for too long. I'm just looking at other aspects. I want to compliment the speakers.
Yes.
The Danish one with the very impressive video. Well done. Also, if the Commission can help with translation, please do ask us. We're not a translation service, but we know the translation service. The regional implementation of what you're doing, fantastic. Compliments to Bulgaria on the implementation of their National Cancer Plan today. That's a great achievement. I'm sure Commissioner Gabrielle will be very happy too. I'm not sure if she was involved. We can't follow her every step. The Cancer Navigator, excellent work as well. And indeed, patient empathy and centricity is all about it. So yeah, I want to stop there. I'll put a link to the Knowledge Center.
Yes, I have to stop you, Kieran, because we still have to conclude and have something else. There is a question for you in the chat, directly to you. Maybe you can answer that in the chat. I saw it coming, sure. So it's directed to you. We also had Romilda, who is a representative in Malta and a national political champion for cancer action on the program. Unfortunately, she cannot join due to conflicting votes in the Maltese parliament, but she sent us a small written statement, and maybe I can ask Richard from the European Cancer Organization to just briefly highlight 2 paragraphs of that statement. Richard, can you speak for her?
Yes, absolutely. Thank you, Guy. We had hoped Romilda Baldacchino-Zarb would join us today. She's a member of Parliament in Malta, a pharmacist by background, and a very active member of national and European Parliamentarians for Cancer Action. Unfortunately, she has been called away at the last moment by a parliamentary vote, but she asked that I read a statement on her behalf, and that was, I believe that our patients need to be well informed while being included for shared decision making. We as professionals, and Romilda is a pharmacist by background herself, are here to discuss with our patients, to acknowledge the difficulties that they face in daily life, and when they are bounded by ethical or religious values. Shared decision making means collaboration with the clinician, supporting individuals to make decisions that are most appropriate for them. Thus, we need to ensure those treatment options together, the evidence, risks and benefits are all brought forward and made available to patients. During that process, the patient can then be fully informed and able to decide based on their preferences, goals, values, as well as beliefs. So we'll look forward to working with Romilda through the activities of Parliamentarians for Cancer Action during this year to see what we can do at a political level across different parts of Europe to make that come into being, and of course continuing our great work together with Kieran and his colleagues at the Joint Research Centre as well. So
nice to hear this support for the shared decision process and the information sharing from politicians and from the Commission. Kieran, I saw from Nicolo that you are welcome to the to join the team on inequalities. I am part of that team as well, so then we will have a chance to collaborate. So thank you. So I would now like to hand over to Nicolo Battisti. He's the co-chair, as we know, of the Inequalities Network of the European Cancer Organization, and he will give the final words of this very exciting 2 hours webinar. Nicolo, you can close the meeting and have a few words.
Thank you very much, Kathy and Guy, for organizing this wonderful webinar. It's been a fantastic opportunity to really remind us as the cancer workforce that really what matters the most is patients, informed decision making, shared decision making, and really put this consideration at the core of what really we do every single day. I would like to, I think we have some slides, isn't it? Yeah. So this is just a reminder that after the meeting today, we will have a report that we will share with all the meeting participants. The recording of these meetings will be available also on Vimeo, again, and available for whoever has attended today. And there is another article, another paper that is being led by our health literacy working group within our network, which is in production, and we are hoping to publish on Journal Cancer Policy. And I'd like to thank Professor Sullivan, who is chairing the editorial board there. Next slide, please. This is also another reminder of our next Community 365 Roundtable meeting. first one of the year. This is going to be on opportunities on pharmaceutical access and value. It's going to be chaired by our immediate past president, Matti Apro, and Miriam Krul, our E.C.O board member and co-chair of our special network on COVID-19 and impact on cancer and our workforce network. The meeting will take place on the 27th of February at 4 to 6:30 Central European Time. We're going to discuss, can you go back to the previous slide, please? We're going to discuss the ongoing changes to the European Union Pharmaceutical Regulation, and again, how we can apply HTA regulation and its relevance to the cancer workforce and our patients. Next slide, please. Yes, so another important development within our network and organization is also a report from the Community 365 Roundtable meeting on cancer care needs in the community setting. We touch upon this specific aspect briefly also today. Most of cancer care actually happens in the community setting. We should always remember this. And we're going to, based on our meeting in October, we're going to share, hopefully in January or early February, a report on how, again, we can achieve successful management, long-term management of cancer, also in the community setting, empower also primary care and allied care professionals in the management of cancer, learn from the hands-on experiences of the cancer workforce, and again, also touch upon new models of care, forms of treatment, to again better support our patients. Next slide, please. This is also a reminder of another very important event, 26th of January. This is going to be affiliated with the Protect Europe project, a EU4Health project that is, as you know, championing gender-neutral vaccination program in the EU member states to provide, again, protection against cancer related to HPV. So the date is in our diaries. If you're interested to attend, please email Giacomo Lazzaro at the European Cancer Organization. The event will be hosted by Arlene Mituta, MEP from Renew Europe. Next slide, please. If you are interested to join our Inequalities Network, please, you're most welcome to do so, and make sure you contact Nela Osmanovic from the European Cancer Organization so that you can contribute to our ongoing work. I would like to conclude thanking Nela Osmanovic and Richard Price that have been really driving forces of our meeting today, for the fantastic organization, Kathy Oliver and Guy Buyens for chairing our health literacy work stream within the network, all the speakers and panelists, Andreas, Saba, Patricia, Teodora, Stine, Gabri, Kieran, and Romilda Baldacchino for the nice message she sent. And thank you all that have been attending the meeting today and for your contribution to our discussion. I look forward to seeing you all at one of the next meetings on the network. Thank you.
Thank you, and bye-bye, everyone.
Bye-bye.
Thank you, Niccolo. Bye-bye.
Thank you.
Thank you, everyone. Have a nice evening.